Evet.
Excellent. Thank you very much for those kind words of introduction. Trine did a fantastic job of sticking to time. I can't promise anything to that, so my co-chair may have to drag me kicking and screaming from the platform, because once I start talking in this area I tend to go on a bit, so just let that be a warning. I'm going to talk to you about some of the findings from our group in Cardiff in this area. What I'm going to do is talk to you first, tell you a little bit about our Bipolar Disorder Research Network study, just to give you a little bit of background to show you where this data comes from. I'm going to say something then about, very briefly mention the genetics findings that are starting to emerge from this work that we're doing, but then I'm going to focus the main part of the talk on what we've learnt from these studies about the postpartum triggering of illness. And I'm going to, if you like, just give you a few of our greatest hits, some of the things that have been published over the last number of years. There's a couple of things in press that are about to come out, and there's one or two things at the end that have been submitted or in preparation. So that's just to orientate you to the next 10 minutes. So this is our BDRN team. This is part of the team. This is our Christmas party last year. The couple of people I need to mention: Nick Craddock, who I work very closely with, has been my mentor in the work that we've done for many years, who heads the work in Cardiff, and Lisa Jones, who heads the team in Birmingham. And the Bipolar Disorder Research Network study has been a collaboration for many years between the groups in Cardiff and Birmingham. It's funded by the Wellcome Trust and by the Stanley Foundation, so two of I think the two biggest funders of medical research, and particularly in psychiatry in the world. We started this network, the Bipolar Disorder Network, in 2008 with a very grandiose idea that we'd expand the numbers of participants we have with bipolar disorder to what we thought at that time was an impossible number of 6,000. We told our funders we could do this. We had no belief that we could do it at all. But what I'm pleased to say is that we're at about 5,800 at the moment, and due by the end of this year to meet that 6,000 target. The idea was it was be a basis for clinical and genetic studies of bipolar disorder to increase our understanding of its causes and triggers, and we would look for genetic and environmental factors that influence susceptibility for this disorder. And we've recruited, as you can imagine, to get 6,000 people all around the UK in many different health boards and NHS trusts. And also had fantastic help from a group I mentioned this morning, Bipolar UK, the third sector organisation, the user group for people with bipolar disorder in the UK. And in fact, a third of our participants in the study have been recruited via that third sector organisation. So I said I'd mention something briefly about the work. Initially, we were part of the Wellcome Trust Case Control Consortium a few years ago now, when our sample size was around 2,000 individuals with bipolar disorder, and that was it was the first real genome-wide association study of complex disorders. Along with bipolar disorder, we were very pleased that psychiatric illness was included in this study that was funded by the Wellcome Trust, but there were a range of other complex medical conditions. And this, I'm very proud, this was a national newspaper in the UK, and it's the only time that study I was involved with, if in a small part, made the front page of the national press, and this was the paper that came out in Nature on that. And there have been some real successes in gene finding, and this is something that's ongoing. I've put something out. This is a slide that's a good few months old now, and since then, actually, with the increased numbers that we currently have, and in collaboration with samples from around the world that total in bipolar disorder now around 13,000 individuals, there's about 9 or 10 very well replicated genetic findings for bipolar disorder. But that's not what the work I'm going to talk about mainly today. I'm going to use the last 10 or 15 minutes available to me to tell you something about what we've learnt about postpartum episodes from this sample. It's been a particular interest of mine, the postpartum triggering, so I've ensured that over the last 10 or 15 years or more since I've been involved, we have really good data on all the women we've interviewed for the study on relationship of episodes to childbirth. If you like, I think it provides a real fantastic counter to the data that Trine has showed us already. Trine has some fantastic advantages, has done some absolutely brilliant work, and she knows I'm a big fan in the Danish registry population. That has some real advantages. You can assess the whole population, but as Trine says, for a disorder that's quite rare of postpartum psychosis, even doing that across the whole population, the numbers get quite small. So our study, if you like, can focus in on some of these rarer conditions in a clinical cohort sample and can allow us to address similar questions in both ways. And actually, some of the data I'm going to show you, I've looked in collaboration with Trine in the Danish registry, and we get a consistent picture from both the clinical cohort and the registry, which is reassuring. Okay, so what have we learned? Well, if you're interested in this, I'd point you to this paper that was published earlier this year in JAMA Psychiatry with Ariana De Florio, who's a clinical fellow with us in Cardiff, was the first author, and this summarised quite a lot of the research that we've conducted. One of the headline findings that we find from this clinical cohort is when we look across the spectrum of illness, both bipolar disorder, and this is a sample of almost 1,000 women who are Paris who've had children with bipolar 1 disorder, over 200 women who've had children with bipolar 2, and over 500 women with recurrent major depression. If we look at a very broadly defined definition of postpartum or perinatal illness, that's any episode, clinically significant episode meeting DSM criteria for a mood disorder in pregnancy or in the 6 months following postpartum, then you can see that across all of these diagnoses, these episodes are really common. What we know from this work and others is that for women with mood disorders, having episodes in relation to childbirth is a very common event. And if we look at the women with bipolar 1, we can see that these narrowly defined women with a mania or a mixed or an affective psychosis, those would meet the traditional criteria for postpartum psychosis. We see that a very high proportion of those groups in this bipolar 1 sample might meet those criteria. If we look at what our data for pregnancy, and this is on data from over 3,500 pregnancies, then we see again that these perinatal episodes are common, but it's this bipolar 1 group that we see this very high risk of postpartum psychosis episodes. What else do we know? Well, one of the bits of analysis we did in that paper that was published in JAMA Psychiatry was we tried to look to see if for these different diagnostic groups the postpartum time was a time of high risk, and actually interestingly found significant evidence for both bipolar 1 and recurrent major depression that women were much more likely to have episodes in the immediate postpartum. But actually, interestingly, we didn't find that for bipolar 2. Women with bipolar 2 disorder in our sample have lots of episodes in relation to pregnancy and childbirth, but women with bipolar 2 disorder have lots of episodes. And we didn't find any particular evidence that those episodes clustered following delivery, which I think is a very interesting finding that we need to follow up more. We've recently done some work, and this again backs up some of the work that Trine has done in the Danish registries, looking at the different risks following a number of pregnancy outcomes, following the risk following a live delivery, following miscarriage and following termination. Our numbers much lower for these other outcomes because we only collected data on this for a limited period. But what we find is that for episodes of mania or psychotic depression, the postpartum is much higher risk. But for episodes of non-psychotic depression, there's less striking a difference between these outcomes. But data again that backs up the work that Trine's done, finding a specific increased risk in the immediate postpartum when compared to some other pregnancy outcomes. This work goes back a while, but being from Cardiff, I'm very interested in genetic factors, and we've shown that family history of postpartum psychosis is a marker of high risk for having an episode of postpartum psychosis. This is a summary slide that shows for an illness like postpartum psychosis with a risk of about 1 in 1,000 deliveries in the general population, something of that magnitude. Women with bipolar disorder are at much higher risk, and again that confirms work from Trine and work from many other groups showing the specific relationship to bipolar illness. But also we found that women with bipolar disorder who have a family history of postpartum psychosis, their risk is about double, in almost 60%. We also know from our work that a really very important marker of being at high risk in subsequent pregnancies is having had a previous episode of severe postpartum illness. In this study that looked at the second pregnancies of women who'd had a postpartum psychosis in their first delivery, we found that their risk was very high. Again, almost 60%, over 50% of deliveries were associated with a severe recurrence in the immediate postpartum. We also did some work that showed us the timing of these episodes in relationship to childbirth. And this was actually a retrospective study where we asked women who'd had an episode of postpartum psychosis, I think there were around 150 women in this study, not when they presented to their doctor, not when they were admitted to hospital, but when for them do they think that the symptoms of this illness began. And what women told us very interestingly was that for the vast majority of these women, it was in the first postpartum week. And for those with onset in the first postpartum week, it was on the first few postpartum days that they experienced this onset of illness. So we have an episode here of severe illness, postpartum psychosis, that has a very characteristic timing in relation to childbirth. There's something happening, as Trine has very well demonstrated in the last talk, about childbirth that triggers off these illnesses, and it's in these first few postpartum days where that high risk really is where that risk is at its highest. And then lastly, I wanted to say something about some work that's been interesting me over the last couple of years now. And initially this came from some genetic findings that we have in postpartum psychosis. So using that data set I showed you before, the WTCC, the GWAS, genome-wide association data we have on bipolar disorder, when we focused in the analysis on that subgroup of the 2,000 bipolar individuals, a subgroup of around 200 women in that sample who had had a postpartum psychosis, what we found was that a particular biological pathway that emerged from the analysis that we were doing as being implicated was a pathway called the vascular endothelial growth factor receptor pathway, which is an interesting pathway because that's a pathway that's been implicated in another pregnancy-related condition, preeclampsia. Now, we've desperately been trying to increase our sample size and replicate that genetic finding. And we've had some success with that, and then more recently we've had some results that we can't quite make sense of. So that work is still not, I'm still not confident to say that the genetics is definitely right. But following that, we've done some interesting studies looking at this overlap between severe postpartum mood disorder and preeclampsia. And actually, this is a link that goes back many hundreds of years from this paper from 1848 that Ian Brockington, the historian of perinatal psychiatry, sent to me when he found out that we'd had this finding. And this pointed out the overlap that was noted back then between these two conditions, and actually, interestingly, was the first time that the association with first pregnancy, with primiparity, was pointed out for both postpartum psychosis and preeclampsia. So we've done some work looking at some of the factors that we know are being implicated in the epidemiology of preeclampsia, and I've listed a number of them there, and I think all of these are really interesting factors that could be looked at in postpartum psychosis. And if we look at the first one, first pregnancies, and Trine's also already mentioned some work that she's done with my involvement in a very minor way that showed this really strong finding of the primiparity effect in postpartum psychosis. And this is work that we did, again, using that model of looking at things in the registries and also looking in our clinical cohort. In our cohort, we looked at this in this sample of over 3,000 deliveries. And what we found was, consistent with the findings of Treen, that we find for bipolar 1 disorder and for postpartum psychosis type episodes, so the severe manias and the psychotic episodes, we find a significant increased risk in first pregnancies. Very consistent with what Treen has found and very consistent with the literature for preeclampsia. But interestingly, I think, is that if we look at what we, in bipolar 1 disorder for non-psychotic depression, we find absolutely no difference in the risk pregnancy to pregnancy. And actually, that works in press now in Journal of Affective Disorders. And then the last thing I'm going to show you is incredibly controversial. I don't know what to make of it, and I was wondering whether I should actually talk about it, but I'm going to mention it briefly anyway. Because one of the very interesting findings in preeclampsia is that there's pretty good evidence and pretty consistent evidence, and this was looked at in a systemic review recently, to suggest that smoking in pregnancy, whereas it's associated with so many negative consequences, so first point to make is in no way with the results I'm going to show you should we be suggesting that the patients we look after smoke, because there are lots of negative consequences. But actually smoking is one of those factors that comes out in many studies of preeclampsia as being a protective factor. So we thought, given this overlap that we find, we'd have a look and see what we find in our study. And actually, when we looked at this in our bipolar sample, smoking was associated, consistent with lots of other research, with practically every negative consequence you could think of. Earlier onset, more severe episodes, presence of psychosis, larger number of episodes, any marker of severity that we could think of, actually smokers did worse. And that's consistent with lots of other literature. But the one thing that was very different was when we looked at their vulnerability to postpartum psychosis. Because what we found is that the smoking group in our parasample had quite a considerably lower risk of a postpartum psychotic episode than the non-smokers. What I should say is our measure of smoking here is poor. It's a lifetime ever regular smoker measure. So we can't say we can't say much about whether the woman smoked in that particular pregnancy or not. But this goes in the opposite direction to all the other severity factors that we found. And also, interestingly, it goes in the opposite direction to non-psychotic depression in these women. That smoking, as we'd expect, maybe is a risk factor for having episodes of non-psychotic postpartum depression. So I think it's interesting. We've tried to make it go away by controlling them for all the confounding factors we can think of, like social class, the education, employment. All of these things doesn't seem to make any difference. So I just leave you with that, and I think we're going to try and publish it. And our hope is that maybe Treen and others in other data sets can look at this to see if this is another consistent finding between the epidemiology of severe postpartum illness and so that's the data I was going to show. As I've said, showed you some of our greatest hits, some of the publications we have, some of the things that interesting findings we've got. We're carrying on with the work. We're part of this international cohort collection for bipolar disorder, which is up to about 19,000 bipolar probants now. And we're doing some work with other members of that cohort to try and establish postpartum, which women that they have with postpartum episodes. We're funding to maintain contact with our cohort, and we're funded for the next 2 years for a prospective recruitment of bipolar women, and there's other work that's planned there. So wanted to thank people on the forum. I think the people I particularly need to mention are Ariana Di Florio, recent PhD student with who some of the recent work I've shown you has been the first author. Just wanted to mention then the help of all those who've helped with recruitment, all our participants. And then lastly, as well as being a professor in Cardiff, I'm also chair of this national UK-wide user group for postpartum psychosis that we're hoping can go international as well. And so any of you interested in the areas here, I'd recommend you look at that website, app-network.org, for some really fantastic information that's really useful to women with that. I'll note that I've got 20 seconds left, so I don't think I'm going to get any questions in, but at least I finished on time, so thank you.